Well, hey, everybody, it's me, Kevin Stevenson. Thanks for joining me on this week's episode of I Don't Care with, me, Kevin Stevenson. So, got a great show today, as always, but this one's even better because this is a friend of mine, somebody that I've done some work with over the past. We worked together on projects. Known each other socially. It's crazy. But anyway, we'll get to that in a minute. But anyway, Jennifer Moody is a partner with ECG Management Consultants. Jennifer, welcome to I Don't Care.
Thanks, Kevin. I'm glad to be here.
Man, it's great to see you again. We haven't caught up in a while, so we might just use some of this time to catch up. But, as I said, I've done some business with you guys over the years, and y'all have always provided great insights for us. We greatly appreciate that. So, but we were kicking around some topics beforehand, and love the topic you suggested. So let's just go off on a tangent on provider networks. So kick us off, Jennifer.
Absolutely. Well, Kevin, I know we just did this work in your market a couple of years ago of trying to figure out what's the right mix of providers to provide care to a community. And it's, as we discovered, it's a delicate balance. It's, too many primary care physicians, and you end up with loss leaders of providers that probably aren't as busy as they need to be. You get too many specialists and you have no one to feed them. So it really is a very delicate ecosystem. And I think a lot of systems are continuing to grapple with the topic of how do I size and build a provider network that meets my community's needs, but also is financially sustainable.
Yeah, and it's difficult. Obviously, I'm making a really duh comment, but every market is so different, and it's based upon so many different things. Your own demographic, but also your location versus other large metropolises, where your patients may be able to go and get that level of care. The services that are provided locally, blah blah blah, you name it. So what are some of the ways that you kick this work off? How do you go about that? And trying to find that delicate balance between primary care and specialty.
Yeah, absolutely. Well, so I think it's a couple of things. Number one, it's getting the market sizing right. Mm-hmm. And I think for many, many years, and I still see this very commonly in systems, is we went out, we drew some boundaries around a market, we roped in the zip codes, and we said, this is our area. And if we were to go out and serve every patient in this area, we would need X number of dollars. Yeah. And it would be perfectly mathematically distributed. And unfortunately, physicians are not butter on toast. You can't spread them evenly. They all practice differently. And in days of healthy competition in markets, it's sometimes very difficult to get the right balance when every individual hospital has their coverage needs. We now see so many procedures occurring in the ambulatory space. Mm-hmm. And so now add to that what's going on in ambulatory surgery centers and in these mega medical centers that we're now building that are ambulatory only, but one-stop shops for wellness. And then you have the complexities of health equity, where not all patients receive care, and not all patients receive care evenly. And so you end up with these really spotty coverage in many, many areas. And, the first piece of advice that I give to health systems is to scale back and be realistic. And that really means trying to figure out what is actual market capture. And I know, we did this exercise in your market, and it's not the same for every specialty. And so, while it was really easy in days past to go out and say, well, my market needs X number of physicians, and I have one competitor, so I'm going to take a 50% slice of the market. In some cases, it may mean you're the only health system that's covering a specialty. In other cases, you may be ceding that specialty to someone else in the market, whether it's a competitor, whether it's an independent group, and saying, hey, we want to be able to just cover the emergency cases that show up, or we want to make sure we've got enough consulting coverage to be able to round on our patients. But otherwise, we're going to have to cede the specialty. And so the first thing I think that systems have to start with is to be grounded in reality.
Mhm.
What is a real catchment area? What does that look like? And every zip code may not have the same market share. You may have diminishing returns as you move away from that bullseye target. You may have natural barriers. Like I run into a lot of health systems that straddle state lines,
Yeah.
and certain cases and certain patients don't or can't cross the state line. And so it really requires having a finite understanding of what the true demand is.
Yeah, the evolution of healthcare, just in my 36 or so year career, back in the old days, the big systems, hey, you're going to be all things to all people. And now, we've really, as you said, we've kind of skinnied that down and said, we've had to be real selective. And hey, we might be the cardiac hospital, we might be the orthopedic hospital, whatever. And then whenever you start dealing with specific subspecialties, you might even have highly specialized procedures that you can expand upon past your typical primary service area. You might be doing something that is just you can reach out statewide, even regionally or internationally in some cases. So it makes your job a lot harder, right? Because then you're having to weigh all sorts of different factors into trying to find the right mix.
Yeah, that's exactly it. And it really, in this day of, I call it micro specialization,
Mm-hmm.
where you have the physicians that, they don't just do their residency, they don't just do the fellowship, they do the post fellowships.
Yeah.
They specialize so heavily. And a lot of those physicians, they want that subspecialty to be their practice.
Mm-hmm.
But the reality is the markets can't sustain them unless they've got that broader regional reach. And every community wants to have those specialists. It's
Sure.
gone are the days where you drove to a major metro area to receive care. Now it's expected that regional health systems are going to have and be stocked with all of the specialties, all the bells and whistles, and there may not be enough providers out there to sustain that.
Yeah, and I can tell you, there's definitely not enough to sustain that. I took a little venture away from the hospital environment for a few years, and when I came back, it was like, what in the world happened? And I used the example of neurology because back before I left, I mean, a neurologist, hey, they did outpatient, they did stroke, they did DBS, they did everything. And when I came back, probably about 7 or 8 years later, I found out that to get all of those, you probably had you had to have 4 or 5 different neurology providers to cover what you needed.
Absolutely. And that doesn't even count, covering for a comprehensive stroke program.
Yeah.
So the neurologist, you have to have the general neurologist, you need the headache
Mm-hmm.
specialist, you need the epilepsy specialist, and then you start to get into, well, now we have to have stroke coverage, which very often the neurologists want telestroke as a first option, but you still have to have somebody who's within the drive radius. So you have to cover the call for that.
Yeah.
And very often those specialists don't want to cover that call. And so suddenly you very quickly have stacked the community with more neurologists than patient demand. And yet you still see patients waiting long periods of time to get into a neurologist because they need to see the generalist first before they can go through the specialty channels. I think another confounding factor has been just the growth of what's going on in our ambulatory space. And I think it's very exciting from a payer standpoint when we really think about getting care to the patients out in the community, keeping patients away from the hospital when they don't need to be there. That allows us to use our hospital capacity more efficiently. It allows us to have procedures in a safe, sometimes what would be considered to be a safer environment and at a lower cost of care. But that's changing dynamics. And so couple of the specialties that I have seen in the last couple of years really explode have been specialties like ENT, urology, podiatry. Those are specialties that don't ever need to set foot into a hospital to provide the care that they provide on a surgical basis. Now, that said, we still need those specialists in the hospital environment. We have patients with head and neck trauma that show up, and we need to have the ENT on call. We have patients that have post-surgical complexities in the hospital, and we want to be able to have a urology consult.
Mm-hmm.
Those specialists don't want to come to the hospital.
Yeah.
And so I've had a lot of requests from communities as we're starting to assess need who come back and say, well, we want to go out and hire 5 ENTs. And the first time I hear that, I immediately will say, why? Because they don't want to cover call?
Yeah.
Well, the reality is there's very few trauma programs and designations in the country that require 24/7 ENT call. And even in the cases where ENTs are on the emergency panel, very often they'll say, great, I can see that first thing in the morning in my office.
Oh, absolutely. Yeah.
And so hospitals are subsidizing that, and it becomes a loss leader, and it becomes one that really never pays off unless the hospital has a stake in the ASC or those ENT practices.
Yeah, that's right. That's exactly right. Well, and you're touching on some an issue too, that the lack of providers, but then the advent of telehealth, and so
Yes.
that really kind of convolutes the mix even more so, because going back to my favorite topic of neurology, trying to recruit that neurologist or that complement of neurologist is next to impossible, because medical schools aren't putting out, or the residency programs aren't putting enough neurology candidates for us. And so you're having to look at the teleneuro aspect, even for stroke programs, in which is not ideal, but that's kind of what we're faced with.
Yeah, and I think that's a complexity in a lot of specialties.
Mm-hmm.
You see specialties that are in high demand, and the residency and fellowship programs are filling, and yet we still don't have enough providers. And so, it's some of that maldistribution. Rheumatology has been one of those, for example, that they have more applicants every year for the adult rheumatology fellowship programs than they can offer slots to.
Mm-hmm.
Every community I talk to wants more rheumatologists, but we can't train them fast enough. And we can't stand up more training programs because there aren't enough rheumatologists to go around that are qualified to serve as program directors or as faculty. So until we grow more academicians in reumatology, we're not going to grow more community rheumatologists. And that's just one specialty.
I was going to say endocrinology is another one.
Yeah.
That we, even before I moved out into Central Texas, back in the Metroplex in Dallas-Fort Worth, there weren't enough endocrinologists back, 10 years ago.
And there still aren't.
No, not at all. So let's kind of explore that a little bit further. The whole telehealth craze that 25 years ago, when I was in outstate Nebraska, we were like this telemedicine hub. We thought we were hot stuff, and nobody else was really doing it. What we were doing, and now, and never thought it. Honestly, never thought that it would expand like it has. And now it's kind of a given. And you're seeing specialties, particularly radiology. I mean, good grief. I mean, most radiologists now can sit at home in their PJs and their slippers and make 7 digits, reading films.
Yeah, radiology has definitely been on the forefront of that. I think the other one where telemedicine really has been a game changer is behavioral health.
Yeah.
In fact, most behavioral health providers now, if you're seeing something that's outpatient, it's going to happen in a telemedicine consult.
Yeah.
We're seeing very few of those physicians that are really, and APPs that are wanting to do anything that's in the office space. And it's, and it's a good thing. It lowers the cost of care because we're not paying for the office overhead. And you have providers now who have a lot more flexibility in their schedules to be able to take on more patients.
Yeah, I mean, you've hit a hot topic for me, because I've had a couple of different tele behavioral health providers on as guests, and there was probably about a 2-year gap between those, and it was just fascinating to hear the differences that's going on in that. Well, and it's such a good thing, because with the rise in the mental health crisis that we have across the country, and we always talk about access. You're looking at finally access points for people in rural America who have desperately needed mental health services for years but couldn't get them, and now that's actually feasible for them.
Well, and I think the other thing with those access points too, and this behavioral health, but primary care as well, is it's really opened up the avenues for our APPs.
Yeah.
You know, you have some communities or some patients that may have been reluctant, preferring to see a physician. And it feels like telemedicine has equalized a lot of that. Now if you're looking for a behavioral health provider, it's not really the letters behind the name, it's the availability and the fit for the condition you're seeking care for. So we're better able to match up patients and use all of our professionals at the top of their license. And that's a critical part of, when we look at ambulatory networks as well, is building out a physician network that allows everyone to practice at top of license. And that's a sticky subject. There's several confounding factors to that. Some of it can be patient care patterns that are ingrained in physicians. Some of it can be systems in terms of setting up compensation plans that encourage both physicians and APPs to act in their best interests and to both cooperatively work together at top of license. Some of it can simply be, jumping through the hurdles with the payers and figuring out the right way to distribute care so that it's reimbursed appropriately. But using providers at the top of their license is a really important part of addressing some of these issues.
Yeah.
The other issue. Oh, go ahead. Sorry.
I was going to say too, and another factor in that too is that associational desire to, frankly, create a barrier and keep that barrier up for APPs. At the same time, different specialists and professionals are saying, "Hey, we're drowning here. We don't have enough providers," and yet they're not willing to relax some of. I don't mean to say relaxing standards, but relaxing the ability for an APP or some other provider to be able to see patients.
Yes. Well, and I think the other touchy subject that comes up is very much this idea of a provider shortage.
Yeah.
We always hear these headlines. And in fact, earlier this year, the AAMC came out with their biennial report and said we could be up to 86,000 physicians short in the U.S. by 2035.
Mm-hmm.
But the key part of that is we could be. If you actually dig into the data of the study, there were some really interesting findings in that study, one of which was the wide variation of whether the shortage we have today is getting worse, this 86,000 number, or if it's actually going to be a lower shortage than what we're seeing and experiencing today. And a lot of that, they did the study differently this time, and they looked at scenarios that were based on could care actually be distributed evenly for all patients? So if we had a scenario that a non-Hispanic white male with diabetes in a major urban area could receive care, could all other patients of other ethnicities, of other health statuses or similar health statuses living in non-urban areas receive the same care?
Mm-hmm.
And that becomes a question of provider preference. And
right.
So we can train all the providers in the world, but if they all want to stay clinging to the coasts in the major cities, then we have a challenge. And the other part of that challenge that's interesting, comes down to two factors. It's provider work style and it's access.
Yeah.
Access is interesting. We did an access survey last year where we called and secret shopped 23 metro markets around the country in 11 different specialties. You probably saw that study, Kevin. Yeah. And what was shocking was the market with the highest concentration of physicians, which is Boston, also had the longest wait times for a new patient appointment. And so the number of physicians doesn't dictate how easy it is to get into a physician when we have other barriers in place. The other confounding factor that was really interesting this year in the AAMC survey data was, for the first time, they broke out primary care trainees in traditional primary care versus primary care trainees in a hospital setting, i.e. hospitalists. Yeah. And what they discovered was the primary care shortage is actually worse than we thought, because of the number of primary care physicians who've taken the hospital medicine or shift-based route. And so we actually may have be heading toward or already have too many hospitalists in the United States. Mm-hmm. and far fewer primary care physicians than we originally thought. And so that's been an interesting shift. And I think, one of the things we've talked to hospitals about over the past few years has been how to counter that trend. And part of it is going to be rethinking what a primary care physician's work life looks like. If our trainees today want to do shift work, and I mean, I can only imagine if I had been in school for an extra 10 years and, had 4 weeks off a year, that the appeal of being able to have time away to travel, flexibility to pursue hobbies and interests, spend time with family would be very appealing. And that 1 week on, 1 week off type of training, type of work experience that gives you 26 weeks a year to do what you want, is very appealing to somebody who's coming out of a training program. And yet we can accomplish that in primary care. There are ways to set up and incentivize primary care for physicians to be able to work 1 week on, 1 week off, taking those evenings and weekends that patients so desire. It just requires us to completely rethink how we run an ambulatory clinic, because our outpatient clinics outside of urgent or immediate care are designed to be 8 to 5.
Right.
Physician practice has traditionally been conducted. And yet we're finding that's not what patients want.
Yeah, no, you're exactly right. Hey, let's shift gears a little bit to one of my new favorite topics, AI. How is AI affecting, your work in and around physician network development?
That's a great question. I was just unpacking this with a colleague today, so very timely. I think what we're seeing in the AI space is it's really about provider productivity. And so it's about having the things in place that will allow providers to, again, practice at the top of their license and to be able to practice more efficiently. And so, things that we think about are being able to deliver patient care more effectively, having AI, consider help with things like clinical pathways, to be able to help with charting and notes and other things that take up physician time. So some of those, things that can be mechanized or that thought processes can come out for things like order entry, for example. We think about what can happen with AI and digital health with patient wearables. So to be able to have better diagnostics with patients, one of the things I think about is care for diabetics now that we have so many wearable sensors that are on the market. What used to be very complex for physicians taking care of diabetic patients can now become very easy because they can log in very quickly and see what's a patient's care pattern been.
Oh yeah, absolutely.
What does insulin uptake look like? What is glucose at different times of the day? How compliant is a patient being? And it allows them to tailor that care. And so physicians that might have spent, a protracted patient visit trying to extract data from patients who are not always reliable relators. Now they've got very efficient data. And I think we're starting to see that come to fruition with wearables in a lot of different specialties that are going to make it much easier for physicians to maximize their patient time.
Oh, you're exactly right. I mean, hey, I'm one of those. I've got the little thing on my arm for my glucose, and as you said, in previous physician visits, that's a 10-minute conversation. And now it's, hey, open your app. You're doing great, or lay off the chocolate guy, stuff like that. And it makes the physician that much more efficient. And diabetes is just one thing. Now, I had a guest on a couple of weeks ago talking about, continuous cardiac monitoring. It's going to be the same thing.
Yes.
And so, I think, and that's something that we talk to our providers about, is about, we want you to spend time with the patients, but be efficient about that time and maximize that time by utilizing technology, utilizing AI or whatever, to make that happen.
Well, and I think the other part of that shift too, when we think about AI, is the shift from sickness care to wellness care.
Yeah.
And, for our primary care physicians to really operate efficiently in a value-based care environment, they have to be focused on wellness.
Mm-hmm.
And so those wearables also allow them to be able to more efficiently manage their patients. I think the other things that are nice with AI are just some of the predictive analytics that can be set up within practices. So really trying to understand, have my patients had their diagnostic screenings? Is there a pattern that I'm noticing with medication refills? All of those, how is a patient's sleep quality? What type of exercise are they getting? Those are all things that with the right wearables can be monitored. The other thing I think that's interesting with AI is it's really expanding the avenues for hospital at home, and you can have more well care. So I just had surgery a couple of months ago, and it was brilliant that I was able to get discharged from the hospital and have nurses, come in and, take care of me in the home setting rather than having to get out and find transport to come to follow up appointments. But also that, I had wearable technology that allowed my doctors to very quickly see, was my heart rate, out of range? Was I having pulse ox issues? Those were all things in the past that really required hospital or step down monitoring that now can be taken care of in the comfort of a patient's own home.
Yeah, no, you're exactly right. I think I'm excited to see what the next 5-10 years looks like for healthcare, because it's going to continue to become drastically different than the type of care that we deliver even today.
Absolutely.
Yeah.
It is exciting. And I think my hope is that level of efficiency allows us to maximize the provider workforce that we do have, and to incentivize more providers to be more community focused when it comes to their care provision.
Jennifer, I just looked at the clock. Holy cow. This half hour has just flown by. Any final words, that you want to get out there?
I think the last thing I would just say is network planning is something that needs to happen often. It's not a one and done activity. Robust health systems are continually monitoring what their provider networks look like, how they're balanced geographically in terms of specialty mix, in terms of payer mix, and making those tweaks and adjustments before they become provider gaps.
Yeah. Well, again, Jennifer, I've had a blast as always. It's always great to talk to you. We can geek out all we want about a lot of different topics, but I'm really glad we chose to stick with provider network development today. So, folks, I'm not going to. I shouldn't say a great episode, but it was. I don't want to pat ourselves on the back too much, but I think it was a great episode. Jennifer Moody with ECG, thanks so much for joining me today on I Don't Care.
Thanks, Kevin.
It was great. Hey, appreciate you as always for joining me. And we'll see you again next week here on I Don't Care with me, Kevin Stevenson. Take care.